Good, what is it, morning still? Afternoon, everybody. Thank you so much for coming. We're going to get started. My name is Peter Smulowitz. I'm just going to do the brief introduction, then turn it over to my team. I'm really honored, though, to be sitting here today with Arjun Venkatesh, with Michelle Lin, with Jay Schuur, and with Elizabeth Schoenfeld. And grateful that you guys are doing this with me, but not saving me a seat on your side of the table. So we're going to be talking about variation in care today. And just to make a very simple, brief introduction, I hope there's going to be something in here for researchers, for leaders, as well as for clinicians. And I think that's the goal, is just to really cover things that we can think about in a multifaceted approach, and maybe open your eyes to some of the novel ways of thinking about variation in care. So with that said, I'm going to turn it over to the first speaker, Arjun Venkatesh.
Thank you, Peter. What I want to start this with is a little bit about clinical practice variation in terms of our history of understanding it and kind of the current policy context around it and why it gets so much attention and why it's a worthy endeavor to target. I normally would never start a talk with a reading assignment, but I figured if you're willing to show up for a session, the last session on a Friday afternoon at SAEM, you actually care about the topic, or you work at Brown and you're here to ask for a raise after the talk. So Jack Wenberg at Dartmouth wrote a paper, probably one of the first health policy papers that got published in Science in 1973. And this spawns from it an entire discipline of what's called small area variation analysis. And basically showed back then that there was wide variations in care in the state of Vermont, in hospitalization rates despite similarities in patients, and did variation research that we can now do because of statistics programs and data sets in a day, essentially manually and with limited computing power back then. And so that's why it was a big deal. Fast forward, it took almost 15 years from that first paper for this paper to get published. And so this was published in the New England Journal in 1989, and Jack Wenberg, again with the team from Boston, did a very simple paper, which was looking at risk-adjusted mortality rates and hospitalization rates in two cities, Boston and New Haven. And putting aside all the ivory tower jokes that would follow that, showed very simply that there was much lower hospitalization rates at the time in New Haven than Boston for Medicare enrollees, despite not really any valuable differences in mortality. And so started to show this idea of there being wide variations in care that we couldn't explain. And this idea of clinical variation quickly changed into a language of clinical variation you can explain from that which you can't. Dartmouth says that there's three kinds of clinical variation that are types of unexplained variation, or lower value types of variation. One is ineffective care. And so there's times when there's variation in care practices and processes despite there being proven or evidence-based therapies. That's just low quality. When you find that variation, that's the most common kind of variation we look for, and we call it a performance gap. The second kind of variation is found often in preference-sensitive care. The most common examples of these are things where there are trade-offs for the patients with respect to kind of competing outcomes. So prostate cancer, should I do watchful waiting or get surgery early? Should I get a knee replacement and risk surgery or just deal with the arthritis? When there's variation here, it may often indicate that there's mismatch between providers and patients, or it may simply indicate that there are differences in preferences, and so it's hard to tease between those two. And then the last kind of variation is supply-sensitive care. And this is a type of variation that's found when you've got more capacity. And so the most classic examples of these are communities in areas where you have more hospital beds, have higher hospitalization rates, despite no differences in outcomes. And here, whenever I think of variation, I think of that as work that's being done to identify waste. So Al Mully from the Dartmouth Institute said this about variation. I'll read it briefly because I think it's a great summary of this whole space of clinical practice variation. If all variation were bad, solutions would be easy. The difficulty is reducing the bad variation, which reflects the limits of professional knowledge and failures in its application, while preserving the good variation that makes care more patient-centered. When we fail, we provide services to patients who don't need or wouldn't choose them, while we withhold the same services from people who do or would generally making far more costly errors of overuse than of underuse. And so that summarizes, I think, the title of this talk, which is trying to understand this variation and figure out if it's good, bad, or neither. There's many causes of variation. I'm not going to get into the details here, but the reason that's important is that variation occurs at multiple levels: the physician level, the hospital level, health system level, community level, and it's driven by a variety of things on both the supply and demand side of the equation. It could simply be that variation is because of the demand of sicker patients with more morbidities. On the supply side, it could be that there's more beds available, more resources around. Variation could be driven by differences in government policies. State Medicaid programs are probably the best example of that. And ultimately, when you're doing work in this space, it's key to really understand what the drivers and causes of variation are and distinguish between the drivers of expected or explained variation and unexplained variation. And so the question that you're left with often when you find a lot of variation, and anything you look at in healthcare will have it, is does it matter? A few measures of variation you'll see, and these will come up in the talks after this that I think are worth putting out there, is if you're a researcher or if you're an administrator and you're reading about variation, these are the things you often see. Bottom left corner are simple measures of variation that people often use, things like range or interquartile range. They express the fact that there's care variation. What's challenging in them is it's often, I call them, they have lower face validity in their explanation. So it's hard to know if you see that there's a wide range of something, such as lengths of stay between emergency physicians in a different department, if that is a concern or not. Is that variation that reflects waste or low quality, or is it just simply expected variation? As you go higher up this scale, you get to more complicated measures, and ultimately getting towards something like a systematic component of variation. Things like an observed to expected ratio that you see are more complicated measures of variation, but they start to hone in on things that have more face validity. And so variation that we can't explain and is beyond what we would expect, and it starts to account for the underlying expected care patterns. When you do that, when you move towards things like a systematic component of variation, you'll see often graphs like this. These are age-adjusted hospitalization rates from the NHS. The NHS does great work on variation and puts out good graphs. The black graph is unadjusted variation. The blue graph is adjusted variation. Almost always, whenever you see risk-adjusted variation models, you see some shrinkage of a curve, but there's a persistence to that bell curve where there's still a lot of variation that exists. And that's ideally what you're looking for when you're doing any work in this space, either as a researcher or as a user of the literature. There's a couple common pictures that get used to depict variation. This is an example from a paper we did. Jay was part of me in medical care a few years ago looking at variation in hospital admission rates. The name of this plot is called a turnip plot. It's really simple and intuitive. The y-axis is the measure of what it is you're looking for variation in. In this, it was ED admission rates. And then the turnip plot itself shows you both not only how much variation there is, but how much density of variation there is at different levels. And you see for different conditions that there's a lot of people packed in the middle, and then maybe a little bit of variation towards the tails, or you see some conditions like it's actually mood disorders there is the middle one that kind of feels like it has a big bulb at the bottom, and then another kind of set of density of hospitals towards the top. And so these kinds of graphs are really helpful in understanding variation. If you're a researcher in this space and you've got access to good data visualization softwares, a newer type of plot I would recommend you use is called the violin plot. This is a description of variation in the space of back surgery, a couple recent papers. And so they do two things here. They took measures I had on that prior slide, the IQR and the coefficient of variation, and they show that over time, and then they use a violin plot to show something similar to a turnip plot but easy to interpret. And so these are the kinds of pictures that people often put up for anything in healthcare. The question is, does it matter? And there's frameworks to address that. So the National Health Service in England says that clinical meaningful variation has these three things about it. It's ubiquitous, meaning it's everywhere. It's not just selectively in a few places. It's persistent, and so if they plot out variation, it's there year after year after year. And third is that it has to create some unexplained problem as a result of that unexplained variation. It either has to create inefficiency in healthcare delivery, ineffectiveness in healthcare delivery, or inequity in healthcare delivery. And if these principles and properties are true to that variation, then it's a worthy target for reducing the variation. This is my last slide, taking that framework and applying it to how the current policy environment in the U.S. is. When you hear about variation right now, particularly as an administrator, there's a lot of talk about risk-adjusted variation in outcomes, outcomes between hospitals, outcomes between doctors, outcomes between nursing homes, whatever it may be. And usually that variation is synonymous with this term called a performance gap. The assumption is if there's wide risk-adjusted variation in something, then that's therefore unexplained. There must be a gap in performance. What's hard to know is the way to reduce or improve quality to just simply reduce variation, have everybody get towards the mean, or is it maybe to lift the bottom and have everybody rise to the high end of that curve? And that's always in clinical context. If it's the latter, and it's really about rising everybody to the top of that curve, a term you'll often see used out when talking about variations, topped out. And in a policy context, topped out simply means there's not enough variation anymore to measure this and to think that there's a performance gap in quality. These types of measures get more and more used in value-based purchasing. And so variation has use there because you can use it for tiering. If you have a process or a service that has a lot of variation in it, you can tier within that to pay people if you want to pay for value. That's a whole separate debate, but that's how it gets used. And then finally, a lot of scorecards, hospital star ratings, letter grades from Leapfrog, things like this also use this variation type analysis in order to populate the scores that they send out to hospitals. And so the same kind of analysis that Jack Wenberg initially started with is the underlying mechanics of a lot of how this plays out in the real world. And it's important to think about that as we talk about it in the emergency medicine context. And I covered that, so I will let Peter go.
Thank you, Arjun. So that was, I think, gives you guys a really great overview of just the topic and the context of variation. Hopefully helping you to understand why it's important, but also why it is really hard sometimes to determine what is the right level of variation, which obviously depends, as we mentioned, on clinical context. So I want to take this in a bit of a transition and focus a little bit on us, the emergency physicians in the audience here and everywhere, because while we've talked about variation in many ways on geographic levels, and I'm going to demonstrate that a little bit more, what I really think is important and what my driving interest is understanding to what degree do the decision makers in all of this matter. Because we are making those ultimate decisions to admit or not admit, test or not test, and are different in many ways from the rest of healthcare because it's not really the supply of emergency physicians that determines whether additional admissions or testing occurs. So the big question then really becomes, does our decision making matter in the context of explaining variation? And if so, why? And, which the other folks will add on later, is what do we do about it? Or what can we do about it? So Arjun already covered some of this, but I want to just show this map and discuss it just in a little bit of a different way. Hopefully the complementary discussion will help you to understand it even further. And this is basically a map that came from the Dartmouth folks also, which demonstrates regional differences or regional variation in spending per Medicare beneficiary. And what's most important about this map is not that there are just regional differences or variation in Medicare spending, but that this variation occurs without concomitant differences in outcomes. So when we see that there is increased spending without appropriate improvements in outcomes or in quality, we sort of refer to that as waste or potentially low-value care. And these kinds of things are seen across many other areas of healthcare, and including in emergency medicine. This is a map that Keith Koger, one of our emergency physicians, presented as part of his work last year. And while the regional distribution of things is different, you can sort of see, again, regional variation, in this case, in the rates of admission from the ED across the United States. But as these two slides start to demonstrate, a lot of the analysis that has been done with respect to variation has dealt with geography. And in many ways, in my mind anyway, geography has more to do with some of the differences in patient variables, i.e. access to care and socioeconomic differences. But as the Institute of Medicine said a couple of years ago, and they put out a report a couple of years ago basically saying that it's not just what's important is geographic variations, but it's important to look at those making the decisions, the decision making and the decision makers, in terms of understanding and further analyzing the importance of variation in healthcare. I think that that's a natural instinct and something that you probably all will understand without a whole lot of effort. This is just one study of one ED group demonstrating rates of discharge versus admission for chest pain. And while it's just a small study, I think that you guys probably all sense this and feel this in your own EDs, whether it's differences in rates of admission or testing for chest pain, or opioid prescriptions or CTs for PE. We know there are substantial differences in the places that we work, and we feel this probably on a daily basis. I'm sure you've scratched your heads a lot and say, why is this other physician doing things so differently than I am? And if there's any residents in the room, you probably sometimes loathe one attending and love one attending because of differences in practice patterns. So this does certainly exist. But to follow that instinct and to tease this out on a larger scale, and this is work in progress that I'm really excited, and sorry I know this is a repeat from the last hour for one person, but I'm really excited to share some of this with you, and also to get your feedback and insights on this. This is a study, as I mentioned, that we're working on now, looking at understanding variation in rates of admission from the ED for Medicare beneficiaries. And this is at the physician level, so not at the hospital or regional level. And what you can see on the left panel is we're looking at physician level variation using Medicare 2013 to 2015 data. And you can see that there's actually fairly substantial width of the histogram demonstrating fairly substantial variation in admission rates at the level of the physician. But then if you go to the middle panel, you can see as you add in a fixed effect for region, there actually isn't that much change there. So across regions, or taking into account geography, there isn't much of a substantial difference. And finally, looking at the right panel, you can see as we add in a fixed effect for the hospital, that we see there's actually fairly substantial shrinkage in the width of the histogram. So what does this mean? This is somewhat counter to my original hypothesis, which is that physician decision-making was first and foremost what's most important, is that there seem to be some, whatever it is, cultural differences, financial differences, ways of adoption of evidence-based medicine and clinical guidelines that are happening at the hospital level. Or maybe physicians, as you work with your colleagues, you tend to get more of a homogeneous practice approach. There's something going on at the hospital level that is dominating the physician individual decision-making. Although I will say that I don't want to discount the individual physician decision-making. This is one study and a very broad look, but there is something to be said about what's happening at the level of the hospital. So let's assume for a moment that we believe some of the slides that I've shown you, and also some of the things that you've heard from Arjun to begin. I'm not going to talk necessarily about all the interventions, as that's going to be the speakers to follow. But what I do want to say is, I think what I'm understanding from my own work and from that of others is that there's really two levels for looking at how we can actually reduce variation in a way that makes sense, which is, as you saw from those histogram plots, is we can target hospitals and look to sort of normalize the behavior at the hospital level, or whether that's a network or an ACO level, but that we also shouldn't discount that gut instinct that we have to improve the variation that's happening inside each hospital as well. And both of those are probably reasonable ways of trying to reduce variation. So why do we differ? Why do physicians differ? Why do we make different decisions? Why is it, to some degree, almost a random event at what happens to a patient when they present to an ED just based upon who's working? Well, I don't have all the answers to that, but I think in the end it really just is as simple as it's all in our brains. We all have different innate and acquired personality traits that make us who we are, that form our decision-making and form our testing threshold, which basically is the point at which the probability of disease is enough to warrant testing. And we've all had different experiences, different levels of experience, different cases that we've experienced, different tolerance to risk or fear of malpractice or whatever else it is that's driving us to all practice in different ways. And so I think it's important just to understand that fact and know that each of us is going to respond in different ways to the experiences we've had, whether we're tired, whether we're hungry, whether we haven't slept the night before. Those are all things that factor into how we make decisions on a daily basis. And so to bring this from a very high level just to the clinical level for a moment, because we're all practicing clinicians, is more than anything, my perception on all of this after having thought about it is that what matters really in understanding how we test and how we make decisions is being mindful of who you are, being thoughtful of your own decision making, and knowing that it differs from that of other people. So there are 5 things I think you can do as physicians here to calibrate your own testing threshold. And I assume that many of you have probably done some or all of these, but I want to go through them and see if you can take something home to your own institution. The first, I think, is don't be rigid. Be open to new ideas, to be able to incorporate new ways of thinking and practicing. If something is the way you've done it for years, again, doesn't necessarily mean it's the right way to do it. obviously I don't have to preach to the choir in this room that education is important, but for those of us, which is all of us, who have busy lives and busy careers, staying up to date on information is really challenging and takes a concerted effort. How many of you here have ever called a patient after you've done with a shift? Well, that's really great to see. I bet you find that to be probably one of the most rewarding things that you do. And also it can calibrate your testing threshold. I remember I had a 30-something-year-old who presented with flu-like illness and a headache and was sent in by her primary care physician for, well, it's not surprising to all of us, consideration of an LP. And I really just didn't think she needed a lumbar puncture. And we had a really nice discussion about it, which will segue into Elizabeth talking about shared decision-making. In the end, did not perform the LP. But when I sent her home, I said, here's my cell phone number. I want you to text me in 4 hours and tell me how you're doing. Why is that not an okay thing for us to be doing? I mean, obviously to share our cell phone numbers seems like it should be something, but how many times do you think people abuse that? Almost never. So not only did she text me in 4 hours, but she sent me a picture of herself the next day smiling and playing with her kid, which gave me great satisfaction that I did the right thing. And actually the funny part of the story, even more than that, is 2 days later she texted me and said, it actually ended up being something totally different that I had overlooked. She had been started on Lamictal a couple of weeks ago and had a drug reaction to the Lamictal. I never would have known that. And I think that's my cue to finish up. All right, so finally, we're sharing the experiences with your colleagues. Talk to people about your experiences, your clinical cases. And to get into the next speaker, use in a wise way clinical pathways and decision tools. Thank you very much for your time, and we'll go on to the next speaker.
So, you know, as I was thinking about what I could add, I think we're all in this room because we recognize there is variation and that's not up for debate. But the takeaway, I think, for me, to preface all this, is that there's variation in the types of variation, right? And there are variations in the types of interventions to reduce the variation. And I'm going to cover some of them, but like it's not one size fits all. And this is going to be specifically with a lens towards low value care, which is where we think about trying to target some of this variation. You know, I like this quote. I do think it's somewhat simplistic, you know, but I do think it applies specifically when we think about low value care and ways that we can reduce variation with respect to that. So I'm going to focus a little bit on choosing unwisely, looking at chest pain admissions a little bit more, and then a very brief overview of some of the solutions. So again, we all recognize that we do either too much or much too much sometimes. So, you know, one of the studies that I did about 2 years ago was survey emergency physicians about how often they choose wisely, you know, and I think we can all recognize that we do, you know, a few too many CT scans, but I think one of the biggest takeaways to me was that when I asked people specifically when you do too much of this particular test, what is the most important reason why you do this test? The colors just show like the reasons for different types of low value care are different, right? And so when you look at something that's relatively innocuous, like potentially unnecessary antibiotics or sinusitis, that's largely driven by patient and family expectations. When you look at imaging for atraumatic low back pain, again, patient-family expectations. And what I actually saw was sort of this like inverse pattern of like patient-family expectations driving non-imaging type solutions, and then as you moved more towards imaging towards the bottom, this concern for serious diagnosis. And so when we think about targeting specific interventions, we need to think about the drivers on the physician level and that these are going to differ. And I would say the same is true when we think about reducing variation in admissions. So one of the qualitative studies that we did was looking at different sites with different levels of variation or different admission rates for chest pain. This is a really common one, particularly because we have really great risk stratification tools and pathways in a lot of places to admit fewer patients with chest pain. And I will preface this by again saying that chest pain is one of many conditions and that there are going to be different drivers of admissions. When you look at the, I think there was a Jesse Pine study where they compared the contribution of physician level and hospital level variation to different admission rates. It differs, right, by condition. And you can think of chest pain and syncope, for example, as conditions where there's a very low probability of a very serious diagnosis, and the patient may not be able to perceive any impending risk of serious outcome, whereas something like abdominal pain, for example, or altered mental status, either the patient or the caregiver is able to at least assess what the trajectory of the symptoms are, right? And so the targets and the way that we're going to address those types of conditions are going to be different. So when we looked at chest pain specifically, again, one of the highest variation conditions, one of the things that we found that was particularly effective with was guidelines and protocols. And again, it's this thought that chest pain is a very risk-oriented condition, and that having protocols and guidelines to adhere to is one way to mitigate that perceived risk. However, you can't have too many. Again, we got this quote, there's lots and lots of protocols, but we really have lots and lots of protocols. And so, making sure that whatever protocol you have in place, is clear, transparent, easy to follow, and seamless. And then again, guidelines can just as easily be barriers, right? And one of the things that we found was a lot of people cited this, AHA 72-hour stress test as a barrier to discharging patients with chest pain. I think there's a recent paper out from Kaiser showing that this really has no difference in outcomes. And so, pushing towards evidence-based guidelines and adherence. So making it easy, again, follow-up was sort of number 1, number 2, and number 3 in terms of ability to discharge patients, and then helping diffuse risk perception, again, whether that's care coordination with primary care, having a cardiologist available. That was pretty rare. I think we only saw that at one site, but these are potential interventions. And then when you ask physicians what they think would be most helpful with regards to, decision making, again, I think tort reform is very high on the list of concerns, particularly in community-based settings. And again, this isn't necessarily borne out with the evidence, right? But there are differences in what we think is actually going to address variation and what's actually useful. And when we look at malpractice reform, right, states that have tort reform policies, there's just as much variation and sometimes higher rates of healthcare spending. Decision support, I think that's one that we think about a lot as one way to potentially intervene in variation. And again, the takeaway is it works for some things, but not for everything. And there was a pretty good systematic review that basically showed, yep, sometimes, but not all the time, right? And I think I'm sure we all have some form of decision support in our institutions. I think, one way to think about this is that we need to be disseminating and sharing, right? Most of this is QI, but if it doesn't work, we shouldn't be doing it. It's just extra click boxes. So again, really only 5 reasonably rigorous studies, 5 reasonably rigorous studies, and 4 of those showed that there may be a benefit, but again, there's publication bias, right? One of the more promising areas is default prescribing, so ED opioid prescriptions. This is an area where Delgado is doing a lot of work. So this is potentially really powerful, right? Just, making it easy, defaulting to a lower number of pills. And then, using behavioral nudges. So peer comparison has been shown to be effective with certain types of prescribing. And, we're competitive, we're achievement-oriented. And so leveraging that as a behavioral insight to get people to move closer to the mean and reduce low-value care. And I will turn it over to the next person.
So I was sort of going to say that I don't do research in variation, but I guess I sort of do research in variation. So my research is in shared decision making, and sort of how does shared decision making fit in here? Do I really have anything sort of to add? Do I add anything by being here? So to make sure we're on the same page, shared decision making is the conversation between the clinician and the patient or the family. If there's 2 reasonable options, 2 medically reasonable options, and there are risks and benefits to each option that may lead different people to make different decisions. And I would add here that sometimes the medically reasonable options aren't really exactly the same, it's not really equipoise, but you've got things in one category and things in the other category that might matter more to one person and might matter more in different ways. And the other way to think about this is if you have a situation where one doctor would do one thing and you know that another reasonable doctor might do another thing, then that might be a place for shared decision making. So that is kind of where practice variation comes in. So shared decision making is appropriate in any area where you know that there is reasonable practice variation. So the elements of shared decision making that are relevant here, the first one I think is the one that's actually most important, is choice awareness, is making the patients aware that there actually is this decision being made that they could be involved in. And then as a clinician, we explain the consequences. We don't just say, here are the two options, it's CT versus ultrasound, it's admission versus discharge. We say, this is what admission means to you, this is what discharge means to you, these are the risks, these are the benefits. And then it's our job to elicit from the patient what that means to them and figure out how that helps shape what we do next. And then you make a decision that both parties are sort of comfortable with. So we know that there are sort of benefits to shared decision making. We know it increases knowledge. It tends to increase the accuracy of risk perception, engagement. There's definitely data that it increases trust. And we now have a little bit of data that it decreases liability, which goes back to why physicians make some of the decisions that they make. And it may decrease healthcare utilization, although that really depends on the study that you look at. So the question is, with shared decision-making and practice variation, is that if shared decision-making improves our ability to sort of tailor our plan to the patient, like personalized medicine that has nothing to do with genetics, it could influence practice variation, but it could influence in multiple different ways. It may allow us to deviate from a standard of care when it's totally appropriate, or it may allow us to have less practice variation because it pulls us back into a better standard of care. It's not totally clear. So would increasing our amount of shared decision-making decrease practice variation? We all know that we don't do as much shared decision-making as we could. That's been shown in surveys, and we all know just anecdotally that we sort of don't have the time and we could do it more. But would it change if we did lots of shared decision-making? Would it change practice variation? So it would if the variation is caused by defensive medicine and we're using our shared decision-making to decrease our defensive medicine. If we're uncomfortable with uncertainty and we use the shared decision-making to sort of address our own discomfort, then theoretically the shared decision-making could decrease what we're doing defensively. If it makes us comfortable doing less, and less is in line with guidelines and in line with what we're supposed to be doing, then shared decision-making could help. But that's only true if the patient is also comfortable doing less. So if you're having a shared decision-making conversation about a CT scan that you probably shouldn't be getting anyway, and you end up getting the CT scan, then you're not necessarily decreasing unnecessary variation. So if our practice variation is due to other factors, illness severity, risk factors that aren't coming through in our data, regional hospital culture, then shared decision-making is much less likely to be useful. And then the same thing if our patients are going to universally choose more resource-intensive choices, then our shared decision-making is not going to help us in this area. It's going to hurt us. Although that last one, I think that the more we do shared decision-making, the more we can convince our patients that increased knowledge may want to decrease your resource intensiveness. So for our own selves, and when we think about whether we're going to use shared decision-making in any particular encounter, is this an area where variation exists? And I sort of asked the residents this. You know, you as a resident work with lots of different doctors. Do two different attendings do this differently? Then this may be an area for shared decision-making. Would any other competent clinician make a different decision than you're making right now? And then the next question is it appropriate to involve the patient? It's not about one blood test that you'd have to explain the blood test, but if it's an area that you really can talk about with risks and benefits that are actually relevant, then it may make sense to employ shared decision-making in that encounter. So I don't think that there's necessarily an answer to whether shared decision-making plays a large role or a small role in this, but it's just sort of another way to think about it. And I'm going to skip and let Dr.
I'm Jay Schuur from Brown, and I'm going to take on the administrative hat. And so we've talked about variation, causes, what individual physicians can do, but what about on the administrative side? How should we approach managing shared decision-making? And the big picture is going to be we have to appeal to physicians' intrinsic motivation, and that's where I'll get to in a moment. I have no financial conflicts to report. These are my funding sources. Like Arjun, I'll point out that this is nothing new. As variation was described in the 70s, made popular in the late 80s, trying to manage variation has been around for nearly as long, and it's very challenging. So we'll review what motivates physicians to change and review some administrative interventions that can change provider variability. This comes from Bob Weir, the late Bob Weir, who did really important work on human factors. And the idea, this is from the human factors world about what actually changes behavior and how we do things in the clinical environment. And the size of the font is how effective things are. So environmental and structural designs are the most effective. Those could be things like EHR defaults, opioid prescribing defaults, or room design if you're talking about hand hygiene. Administrative controls are second most effective. That includes audit and feedback. And last is education and training, which tends to be the thing that we first jump to. Now, I put this up here because there's not really an environmental solution for variation. So it really falls largely into the administrative controls. At the bottom, I put question marks around behavioral interventions, all of the newer stuff around behavioral econ and psychological interventions. Most of these are still relatively untested. The one that has been shown is normative feedback, showing people's behavior compared to their peers. So what are some administrative controls that we can think about for variation? Clinical decision support in the EHR. So depending on design, clinical decision support could be an infrastructure if it's really well designed and goes into the work floor, or it could be an administrative control if it's poorly designed. We all know those pop-ups that don't fit into the workflow, and that's more of an administrative control. Audit and feedback is the most common option we have for provider variation. That can be private, just sharing the information with an individual provider, maybe with their peer group de-identified. With peer group, meaning you show it to the whole group and everyone knows where everyone is. This is a normative intervention and it appeals to our social cues. And then public, which ultimately is really trying to shame people into changing behavior. We can use financial incentives, or we could use discipline, things around licensure or hospital privileges. So it's interesting to think about what actually does motivate health professionals. These are all different things that pop out, and we probably each have our own opinions on this. Where I went for this talk is the book Drive. Who's read this book or listened to it? I would highly recommend it. It's available both in book form and audio. And Daniel Pink summarizes the psychological and behavioral econ literature on what motivates individuals. And I'll give you a couple takeaways about this. The first is that motivation really depends on task type. If you're doing routine structured work, like picking fruit, then extrinsic motivators like money are very effective. But if you're doing complex knowledge-based work, which is the vast majority of what we do as physicians, then intrinsic motivators are the things that actually motivate people to change. And the caveat is once people perceive they're reasonably paid. If people don't perceive they're reasonably paid, then extrinsic motivators may get you a little place. And he puts together a theory that there are three elements to intrinsic motivation: autonomy, purpose, and mastery. And so what is autonomy? Autonomy is our ability to control our work and our work environment. In some way, physicians immediately see areas to control variation as a threat to their autonomy. So we have to make sure that what we're doing around variation doesn't actually threaten their feeling of autonomy. Second is mastery. Some physicians are going to think of guidelines as cookbook medicine, and actually the opposite of this idea of mastery, which is one of the things that motivates us. And then you want to appeal to purpose. I think that's easiest in variability because there's a good case that variability is the enemy of excellent patient care. The other thing to think about is managing the barriers to intrinsic motivation. So fear of malpractice can overwhelm engagement in reducing cost because people feel so threatened that they're not going to engage in the other aspects of it. So creating work and financial rewards really depends on the type of structures we have. If you're doing routine structured work, then financial incentives are useful. Very little of what we do fits that, except for rapidly going through patients. And that's why RVU-based motivators are effective at getting physicians to see patients more rapidly. But financial incentives are not always effective, and they can be counterproductive for complex work because they define in very narrow scope what someone should do, and the things that are out of scope may be suppressed. The second thing is that typical financial rewards that we give to physicians on the margin are smaller than what has been shown in the literature to generate change behavior. Generally, a change behavior, financial rewards need to be in a 10 to 15% range of someone's compensation. And most of the rewards that we give people are much smaller than that. You may think, well, the annual bonus is 15%, but when you actually divide that out by all of the things that go into that, it's much smaller. What they can do is bring attention to a task. So if there are lots of things on our plate, and your department or hospital says, this year we're going to have an initiative around chest pain admissions, and there's going to be financial rewards, it will get people to pay attention to chest pain. The question is, are they going to not pay attention to something else that's important? That's something to think about, but it's by itself not a reason not to think about some level of financial incentive. And so who has actually done this work and been successful? That's a good place to look. Who's familiar with Intermountain Healthcare? Anyone from Intermountain Healthcare? This is the system out in Utah. Brent James has been their chief quality officer for about 25 years. And they have probably been the most successful in the country, maybe along with Kaiser, at managing physician variability. And they've worked at this for years, and they have a very set approach. And the good news is it's replicable. The bad news is that it actually is challenging and requires a fair amount of work. The approach is to identify a high priority process, identify respected physicians to be project champions, create evidence-based practice guidelines, and don't let the lack of evidence be a barrier to creating those guidelines. Build the guidelines into the clinical workflow. Use the guidelines as a shared baseline, meaning that you're going to say that that's the starting place, but if physicians have a reasonable reason for varying, they can do it, they just need to note it so you can collect that information. And then learn from that variation over time and address the reasons for variation. And this involves sharing information with the providers about their performance and actually following up on the things that make people vary. For example, if in the chest pain case, people vary because there's not access to rapid stress tests, then you either have to get the group to decide that they're not going to do rapid stress tests or find a way to get those rapid stress tests, and then you can get that variation off the table. So what are health policies going to do administratively for physician variation? One could do a whole long talk about MIPS and MACRA and all of these things, but I would summarize it pretty simply. In the big picture, reimbursement policies are going to move away from fee-for-service and more towards risk-based approaches or approaches where quality determines payment. Risk-based payment means that physicians and hospitals are on the hook for costs or quality. So managing variation is key to success under this regime. And so unfortunately, the payment systems themselves are not going to solve the problem because the MIPS rules and criteria are so complex that for the frontline physician, it's not going to be a motivator for them to change their behavior. And so as administrators, we need to start thinking about how to build these systems to manage variation in effective ways with frontline clinicians. That's how we'll be successful in the Medicare and other programs. So my summary is that you want to appeal to physicians' intrinsic motivation, so think about autonomy, mastery, and purpose, and align your interventions there. Develop and implement evidence-based guidelines, but don't let a lack of evidence prevent guideline implementation. If there's something that there is enough consensus in your group, you can still work forward on a guideline. Feed data on performance back to clinicians and the peer group. That takes advantage of normative behavior. And then, in terms of financial incentives, they can bring attention to a task, but they're unlikely to marginally add beyond the other tools you have in your toolbox to get individual people to do better. So I think at this point we'll open up for questions or comments to anyone in the panel.
This is a great talk. Thank you all. Yes, oh, sorry. Jordan Swartz from NYU. It remains that if you discharge a patient, let's say with chest pain, right, they have that possibility of coming back with an MI that you miss. And sure, there's the legal, but there's also just the shame of, I missed. Whereas if you bring a patient into the hospital, we wash our hands clean. So I was just thinking that it seems like there's just a major asymmetry in these decisions. And whether there's been any work, I was just thinking in my head, like, you know, reporting, like we give our providers bounce back rates and those cases. We don't give them is the hospital-acquired pneumonia. We don't give them the financial, especially now with the high deductible plans. How many patients did you bankrupt bringing in a low-risk chest pain? And it's sort of funny, but maybe it shouldn't be, in that it should be a normal part that we are responsible for all these aspects of our patients. And do you know of any research that's been looked at feeding back to providers the downstream effects of their decisions?
So I'll make one comment, and then it's interesting because I have done a lot of work previously with providers about healthcare-associated infections. And you do focus groups with providers, and they all want to know, give me the data on how many infections we caused because we didn't wash our hands. And the real challenge with that is that most of these outcomes are so rare that it's hard to feed them back. When you started talking about cost, my initial reaction was a little bit negative. We do know that studies that put cost into the EHR can reduce ordering. The question, and there's a real debate on how good this is, because are you going to use that information differentially, and is that going to be used differently on different types of patients? I think your idea actually about the patient shared costs is really interesting because it's less about cost than it is about the responsibility and the potential harm to the patient.
So,
Sorry.
well, I was just going to add, so it was not presented this year, it was presented last year at SAEM, and we had a chief resident who starts to get at this feeling of competing measures around performance and competing measures of variation, and so we took the common measures, 72-hour returns, admission rate, CT utilization rate, and kind of patients seen per hour. And all of these have a bell curve of variation, as you would expect. If you do risk adjustment, they all have variation. What's interesting is that these things are not necessarily inversely correlated always. We found that, you know, people will say, well, I CT more patients so that I don't have to admit them. Our high CT users were our high admitters in our institution. People will say, well, if I admit fewer patients, I'll have more 72-hour returns. That is true, but it was pretty marginal and only for those at the extremes. And so I think part of this is using your local data now that it's so much easier to query this kind of stuff, to be able to actually look at what the underlying relationships are and then putting that in front of people.
I just want to make one small additional comment to that also, which I think you guys covered just about everything. But I want to go back to the first thing you said, which is about feeling ashamed. And this is a whole other area of interest for me is Lawrence Levy, who's the former chief financial officer of Pixar, who's now sort of a guru of physician wellness, talks about this thing called the narrative of perfection. And I think at its core, we all have to start changing that. There is absolutely no such thing as perfection in medicine. And also there needs to be an acceptance of uncertainty. But we as all together as a group have to start accepting that and reducing the feeling of shame that we all feel, which then will have, I think, downstream effects of reducing the fear we have of making a mistake, a malpractice, or whatever might result from that. But it starts at that very core, and perfection is impossible in medicine.
The last comment I'll make is that cost is really bimodal when you look at particularly patients, but also physicians. And so you either have the patient who really wants to hear about it, or the patient who like really, really does not want to hear about it. And so, and with cost and with this risk now versus potential risk later, right? We're conditioned to think more about the risk now, but these are really great areas for shared decision making because if the patient's values differ, then you can base it on those.
Other comments or questions?
Hi, Kevin Manjal from Mount Sinai. I apologize because I'm still formulating the question, so it's going to come out a little jumbled, but I really appreciated the slides I'm sorry, I don't remember the name, you presented about the difference in sort of, doctors across a larger region, and as you get to a micro hospital, individual decision-making kind of gets uniform. My personal belief is that it has a lot to do with how the choices are framed at that local institution. And so I'm fortunate to work at a place where we have a hospital at home program and we have a whole bunch of other community resources. It makes it easier to say, okay, let's discharge the patient. But just about 2 weeks ago, after about 2 years of doing this urgent referral to a specialist, we finally got back some feedback that our 3 to 5 day referrals were actually taking about 18 to 20 days. And so now we're all rethinking some of those discharges and how we're doing that. So I guess my question is about whether there's research kind of looking at the way some of these transitions of care, types of opportunities and things are, and sort of how that actually relates to variation in decision making from the physician, but also, perhaps some shared decision making or all these other things. My question's not perfect, but I'm really interested in it.
I was just going to say Kristen Rising's doing a lot of research on transitions of care and targeting different types of chronically ill populations, and so we can talk offline, Kevin.
Anyone else? What I would say is, I think a number of us talked about variation in admission because it's something we're all interested in. Most of the work on variation that's been done has not focused on that, even though some of the early studies pointed it out. It's focused on procedures, on ordering of tests. The admission decision is obviously a much more complex decision that involves testing, treatment, and risk, and so it's a great opportunity for research.
Hi, Pierre Borzak, MGH. What's your name on the end?
Elizabeth.
Elizabeth, have you looked at your influence on variability and shared decision making in your department, and how your research has affected and maybe narrowed the practice variability?
It's coercion.
Yeah, so I haven't looked at it officially, but I have been told by my colleagues that it's going to be more challenging for me to run the randomized controlled trial that I want to, because my discussion of shared decision making has bled. I tried not to be on a soapbox for a couple of years, and then at one point someone told me that I had failed to not be on the soapbox. So I think that it's a cultural thing, right? If it's the norm at your institution, then it starts to be the norm. And I think that, I really love that the residents drive that. I know that my residents say, hey, can we use phenobarb? And I say, oh, we're using phenobarb now? And then we sort of switch to phenobarb, so they really drive it. So, but the problem with that is that that's like institution by institution. And that's why you find champions for each of your things, and you sort of do them. Tala has something to say, and she's at my institution behind you, so she might have something. And speaking of, if anyone wants to come up to the shared decision-making didactic, it's right now.
I thought that was the last one. You're still.
No,
All right, we're all following you then. Sounds good. Thank you very much for your time today. We'll happily answer additional individual questions. We appreciate it.
That was great.